And see, shall we start or wait for 2 more minutes?
If you want to start, sir, you can start as per your convenience.
I think I think 32 people have joined. I think just 2 more minutes we'll wait. Okay.
Sure, sure, sure.
Good morning, sir.
Good morning, Umar. Shall we start or wait for 2 more minutes?
2 more minutes, sir. We'll just wait for 2 more minutes.
करता
So you want to start? Hello.
Okay, shall we start now?
Yes, sir.
Yeah, I think we'll start. Okay. Good morning, everyone. The pattern is just like the same. So I will start my share screening. Sorry. Can you see my slide?
Yes, sir. Yes, sir.
I will start. So good morning once again. So as usual, we'll start with the small case first, a short case first. This is a story of a 17-year-old girl who went an ophthalmologist with a history of defective vision of right eye for the last 5 days. Ophthalmologist noticed that the visual acuity was 6/6 bilaterally, fundi were normal, pupil reaction normal, there was no RAPD, and this is the field deficit which they found. That on the right side of the eye, OD means right, OS means left, there is a right field temporal cut. The doctor could not explain the field loss and referred to you. What do you think is the likely diagnosis? Anyone you want to unmute can unmute themselves and then can voice their opinion.
Sir, any history of headache or fever?
No headache, no fever. But other people also, are they not able to unmute? I don't know. And then they can speak also. Once whoever wants raising the hand, you can unmute them. Any other opinion? Okay. But this field deficit is got unphysiological. How can only one eye temporal field can occur? Okay. So, but however, any field deficit respecting vertical meridian should be viewed with caution, because you suggest a chiasmal or retrochiasmal lesion. Sometime back I had a bad experience. I found this vertical meridian loss. I thought it cannot go with the organic deficit, but turned out to be a pituitary tumor. So how can it be confined to one eye? That's a problem for you. So theoretically, say this anterior chiasmal compression here affecting the nasal fibers of one optic nerve, a compression from this side, can theoretically cause a field deficit like that. Only the temporal field can be cut. But what is anything odd if you postate a lesion like that? Because if you compress the optic nerve here, in the medial part, we're compressing the nasal fibers of that particular optic nerve. That area contains the inferior nasal fibers of the contralateral optic nerve, which loop anteriorly to the ipsilateral optic nerve and then go to the before going to the ipsilateral optic tract. Okay, that means that this, if a lesion compressing the optic nerve proximally close to the optic chiasm, is likely to compromise the inferior nasal fibers of the contralateral optic nerve. So you get a particular scotoma, which you all know called the junctional scotoma or junctional scotoma trachea. So this is what you expect if you get a proximal optic nerve compression here, junctional scotoma. So in this patient, so what will you do now?
Sir,
So
anteriormost part of the occipital opposite side.
yeah, that part is a very good thought you have considered, Paramo. But the problem is that is a temporal crescent. That temporal field never will occur on the whole of the temporal field. Only the temporalmost part of the temporal field in a moon-shaped fashion will be affected. So this kind of a temporal field deficit cannot occur.
So involvement of the optic nerve more distal to that curve, sir.
Distal to
The optic nerve, that curve is there, no, sir. That junctional, slightly distal to the field.
That's exactly the point I showed you. That area, the optic nerve, that's the area which affected can cause contralateral temporal field deficit. The same.
No, if the involvement is slightly distal to that one, sir, then that temporal junction.
If you're distal to that, it's likely to involve the opposite fibers also. These fibers also coming to the opposite side. If it's distal, suppose I am taking the lesion here, then you would like to have bitemporal hemia now.
No, proximal to that, not distal.
Proximal to that, agree. That part agree. Proximal to that, that agree. Perfectly agree. Perfectly agree. That's correct.
Any anomalies in the tract, sir, anatomical anomalies can also cause this, sir.
But usually in optic nerve compression, this kind of a temporal field is very, very uncommon. Wherever the side of compression is, so from the nasal side or temporal side, because that is usually what is a central scotoma, because the macula papilla bundle fibers are most vulnerable. So wherever the compression is, you like to take a central scotoma. That is why in optic neuropathy is an optic nerve compression. you get cerebral scotoma. This kind of a temporal field is very uncommon, except in case of a chiasmal conversion. Okay, that's a possibility. Definitely, you have to keep in mind. So, what do you want to do now?
MRI.
Okay, then the patient was sent again, look for junctional scotoma. That knows also what is the diagnosis. So, say, is it functional? Are you confident to send it to a psychiatrist? Or do you want
No.
MRI or the cellular region to be done?
Again, with
MRI, sir.
optic nerve lesion, such a vertical thing would be odd, no, sir?
Very
Such
good.
a
Very
clean
good.
vertical.
Very good. Perfectly right. In this kind of vertical meridian as a chiasmal or retrochiasmal is perfectly right. That is, theoretically, that evolution is possible just by extrapolating. If it is near the chiasm, is possible, but not in optic nerve, as you correctly said. Usually, some scotoma is the one occurs. Anything respecting vertical meridian, think chiasmal or retrochiasmal. So the MRI was done normal. Now, what do you want to send a psychiatrist?
So VP, sir. The-
These they cannot help, no, because only affected the one half of the fibers are affected. The other fibers will carry the impulse.
You did MRI only for the chiasm or not for the
No,
cerebrum?
everything is taken. Whole part of the brain was normal.
What about retina?
Retina is also normal. Retina, again, such a kind of field of say retina is extremely uncommon because one there one half is affected. Down agreed. Inferior and superior altitudinal hemianopia is very common.
What about the pupillary reflex from the scotomatous?
No, everything is normal. If the examination is normal. No, how to prove it functional? I thought it's functional, but how to prove it? In a way,
Menace
By
reflex,
the
sir. Menace reflex.
many also can't help you. No, it's coming into one. Closing one eye, you can go to that side, but it's not how difficult it is sometimes to diagnose a function based on many ways. Difficult.
Sir, MRI contrast was done?
Yeah, contrast also no. No, but the point what I'm trying to say is that such a field is very, very unusual. It's more often you find in functional patients, such a complete temporal field loss. But how to prove it? I'll tell you what I did was I checked the field with both eyes open. And this is what the patient complained. You got the point. See, when both eyes open, you check the field, you find that still the right half she is missing. That means it is functional. You got the point. So, for example, to make it more clear to you, this is the normal monocular vision. This is the left eye, this is the right eye. This right temporal field, this is my right nasal field. See, the right nasal field is coming from the from the temporal retina. Now, see if the patient, this is the picture of our patient. That means the right temporal field is affected. That is our patient has. Suppose you are viewing with both eyes, the field should be contributed with an overlapping field. So if you take the right temporal field in such situation, is contributed by the right temporal field of the right eye and the left nasal field of the left eye. So both will come to that side. That will overlap over the binocular vision. On the other hand, the right side will be contributed by right temporal field as well as the nasal field of the left eye. So what essentially happened means if he has got a field loss of one eye like that, if you view with both eyes, only this part should be blind. The rest of the area, the binocular field entirely will be normal. So the patient will never give a complaint like this. If you give a complaint like this in binocular field, that means it is functional. It turned out to be functional in this patient. Now you can confidently, there are many methods by which you can detect unilateral functional observation. There is fogging the good eye while the patient is reading the chart with both eyes. Suppose you have patient reading the chart, patient feigns blindness on the right eye. Then what you do with that, serially put convex lenses on the normal eye without knowing, telling the patient which power it is. And in effect, you are masking the vision of one eye without the patient knowing. The patient will still continue to read, telling you that the right eye was really normal. The other is tunnel vision, which you all know. And ask the patient to bring together index fingers after patching the normal eye. See, this is the normally what happened in the case of a organic vision loss. The field deficit or the field area or the normal field will increase the distance, move away from the screen. But it will repeat the same throughout when the patient is close to the screen or away from the screen. That's called the tunnel vision. The funnel vision is the normal one. The tunnel vision is fine, think of the funnel. And the other simple method is this method. See, the patient is asked to bring the fingers together with eyes closed, one eye closed. Suppose the patient on the imagine the patient has got visual loss on the left eye. She's complaining of visual loss on the left eye. You patch the right eye, ask the patient to bring the fingers together. This patient will feel the finger like this. Okay. But normally also when you close both eyes, you can bring the fingers together. Like this, what is shown here. See, if your patient brings the fingers like this, that means patient believes that the patient cannot see the fingers, and so the hand cannot be approximated up properly. This is again fooling the patient to bring out the real function of the vision. If the patient's got binocular loss, total loss of vision, the other method is that ask the patient, you take the hand of the patient, you by yourself, and bring it to the all direction of the field. The patient will be asked to look at the finger. Even if the patient is totally blind, the patient can deviate the eye to the direction of the moving finger because of the proprioceptive input. The faint patient, the functional patient will not move. She says that I cannot see when the finger, I cannot move the eye. Then other method, enable to touch, then the field loss will be various star-shaped on this kind of a field loss are also suggested. Functional field loss, functional loss of vision. So any further questions? Then I'll go to.
Madhu, can you hear me?
Yeah, please. Yeah, Subhash, I was waiting for it because I bought the cases for it.
I think, that was nice.
Yeah.
I had a similar patient recently I discussed with you. My one question is that can functional patients have homonymous deficits like homonymous quadrantinomias and homonymous hemianopias? They can have.
Yeah, they can.
And can this be a clue that if in these homonymous visual fields they cross the midline, can that be a clue towards functional etiology? Or for instance, if there's a right temporal defect, but they go past the midline and go a little bit to the other side also, can that also be organic, or that is a clue to functional?
No, if it is going to the opposite side also, that means the opposite side is also affected. That can cross to the opposite side, but with unilateral it cannot occur. That's the point. See, if the field deficit is crossing to the opposite side, that means it has to be either both optic nerves are affected, or chiasm is affected, or the least has to be homonymous affecting retrochiasmally. Retrochiasmally means they can be that too bilaterally actually affected if it crosses the midline of the one field.
Yeah. So midline can be crossed in these hemianopias.
Yeah, in the sense, suppose you got a retrochiasmic lesion, it will be only confined to homonymous field, right temporal and left nasal like that.
Yeah.
If that field crosses to the nasal side, that means the lesion has to be bilateral. Suppose it's got a right eye is affected both sides, left eye is also both sides, mean both field means it has to be bilateral. Or it should be lesion has to be only one eye, it is obviously in the optic nerve, as is correctly said.
Thank you.
I don't know whether I made it clear to you, but
Yeah.
Okay.
So there is an entity called hemivisual VP, sir. Can it be useful in this type of case, sir?
Then it's called hemifield stimulation. Hemifield VP stimulation. That's a good thing we can do, but I have not done that. It's a cumbersome technique, but not practicable in bedside.
Sir,
yeah.
Sir, you told us that there is a case of pituitary lesion, which present lines. So, what to say? What finding in that case? How do you
In that case, I was a junior neurologist at that time. So I did not check the contralateral upper temporal field cut. The patient had upper temporal field cut.
Okay.
Okay, next two case, a really good case, really fantastic case. Little difficult but good localization cases. This is a 34-year-old man who noticed sudden severe pain in the right side of the neck, radiating to the right upper limb, when he casually jerked his upper limb as if he was throwing a ball. I will show the video of that part, how he was doing the history part. Then you can deduce what was the action he was doing when he developed the pain. The pain was so severe that he got some relief only by lying on the right side with the right hand supporting his head. A few minutes later, he noticed functions of the right hand, and when he started walking, he noticed imbalance with his right leg. His right leg was not moving as well as on the left side. So he had a sudden severe pain. Within minutes, noticed weakness of the right hand and right leg. He was admitted to the hospital, and the doctor detected decreased pain over his left lower limb. He was put on treatment, and within noticed improvement in his pain and weakness within 2 days' time. After 2 days, it started improving. Now, this history, I think the Malayalam may not be able to understand. I will convert it in, change, and I will tell it in English. But you can see the action by which
അപ്പോൾ 6 ദിവസം മുമ്പ്
started
ഞാനത് സെറ്റേലിംഗ് ഇരുന്നിട്ട് ബുക്ക്
was reading it.
വായിച്ചിരിക്കുകയാണ്. അതിന് മുമ്പ് ഒരു കുഴപ്പമില്ലായിരുന്നു. ഒരു കുഴപ്പമില്ലായിരുന്നു, ഒരു പ്രശ്നമില്ലായിരിക്കും. അപ്പോൾ ഇങ്ങനെ
He was doing like that.
അതൊന്ന് കുടഞ്ഞാണ്, ചുമ്മാ കുടഞ്ഞാണ്.
He just checked his head.
എറിഞ്ഞു കഴിഞ്ഞപ്പോൾ തക്കുന്നൊരു
Some
വേദന.
noise he heard.
ഇവിടെ വേദന വെച്ച് ഇങ്ങനെ ഇവിടെ നിന്ന് ഇങ്ങനെ അങ്ങോട്ട് വന്നിട്ട് ഈ കയ്യിൽ ഇങ്ങനെ അപ്പോൾ കയ്യിൽ ഇവിടെ കയ്യിലാണ് വേദന കൊടുത്തത്. ഞാൻ ഇത്രയേറെ പിടിച്ചു വെച്ചു, നിൽക്കാൻ പറ്റുന്നില്ല, താങ്ങ് കൊടുക്കാൻ പറ്റുന്നില്ല. അപ്പൊ കഴുത്ത് തനക്കും ഇങ്ങനെ മുകളിലോട്ട് എടുക്കുമ്പോഴോ കഴുത്ത് ചിരിക്കുമ്പോഴോ വേദന കൂടുന്നുണ്ടായിരുന്നു. ഞാൻ ഇങ്ങനെ കൈ കുത്തിക്കണം, അപ്പൊ ഒരു ആശ്വാസമുണ്ട്. അപ്പൊ ഇങ്ങോട്ടാക്കുമ്പോഴേ വേദന കൂടുതൽ തോന്നുമായിരുന്നു. വേദന ഇത് വിട്ട് കഴിയുമ്പോൾ വേദന കൂടുവാണ്. ഈ പൊസിഷനിൽ നിന്ന് മാറ്റി കഴിഞ്ഞാൽ ഞാൻ എന്റെ കൈ മേപ്പോട്ടൊന്ന് കൈ പൊക്കി ഉടനെ കൈക്ക് വിലപ്പുറം വെള്ളം അടിക്കുന്നത്. ആ വേദന തുടങ്ങി എത്ര നേരം കഴിഞ്ഞിട്ടാണ് വിരലിൽ വിലക്കുറവ് കാണുന്നത്? ഏകദേശം ഒരു മണിക്കൂർ കഴിഞ്ഞു.
That's the essential part of the story. Now, go to the examination finding. Tone was normal, but hand grip was weak on the right side. It is overcome, but not on the left side.
ഈ കൈ പൊക്കിക്ക് ഇങ്ങനെ
Deltoid was normal,
അതേമാതിരി പിടിച്ചോണേ മതി.
but biceps was might be.
കൈ ഇങ്ങനെ മടക്കി പിടിക്കാൻ നോക്ക്, പറ്റണില്ല. ഇത് വീക്കാണ്. ഇത് പിടിച്ചേ.
Left side is biceps was normal.
കമ്പ് പോലെ പിടിക്കും.
Was normal.
ഇത് പൊക്കി പിടിച്ചോ. ഈ വെട്ടിൽ പൊക്കി പിടി.
And extra quality long is also. Hand grip was weak because was finger presses were normal. All muscles were. Then flexion was the right side, normal on the left side. Flexion was also gate 4+. However, I could break the dose. Adapters good. Now coming to the reflexes. Right biceps is absent. Left is well elicitable. Left supinator normal. Right supinator absent. Biceps was just elicitable on the right side. Just elicitable on the right side. Question was absent. Abdominal reflex I could elicit only in the just diminished bilaterally. Check was 1 plus on the right side, almost absent right side. Left side is eligible and was absent. Check once. It was not eligible. Left side was eligible. Really eligible, but right side is
Left is slightly brisk when compared to right side.
and both angles were absent. The banda was upgoing on the right side. Left was flex. Taking the pain, when you wear the pain normal. That's the area where he put the normal. On the left lower limb, after that area. These are all normal.
Pain impaired bilaterally, sir.
No, only on the left side. Only on the left side. I'll find out the way. I'll show you the level that's the area is showing the decreased pain level. On the right side is. And coming to the posterior cord, I think I'll not spend time on that. They are normal. Vibrations and joint presence are all normal. Everything is setting normal. That's it, not normal. But again, there's some clumsiness to the walking with the right leg. It's fast. Burning touches like
ഞാൻ കുറച്ചുണ്ട് കേട്ടോ. ഞാൻ വിളിക്കാം.
Okay, so that's the finding. So examination finding summary, tone was normal. Weakness confined to the right upper and lower limb. There is weaknesses for right biceps, finger extensor pollicis longus, and hand grip on the right side. On the lower limb, weakness of right dorsiflexus and mild weakness of the right flexus. Detail the upper limb, left biceps supinator triceps normal. Right side biceps supinator and finger flexion absent. Right biceps is 1 plus. The lower limb, right knee jack is absent. Left is 2 plus. Both angle jacks are absent. Plantar upgoing on the right side, indefinite on the left side. Sensation decreased pain below D6 on the left side, but and posterior sensations were all normal in both upper and lower. So these are the findings in this patient. So where is the site of use?
The cervical cord, right side, anterior part.
Very good. At what level is the localization?
Maybe C5, 6.
C5. But triceps also absent, percussion is absent. Right knee is absent.
And spinal artery involvement, you can get a long extensive lesion.
Okay, correct. The possibility, very good possibility.
But the problem is the left angle jack is also gone. That
Yeah.
cannot be explained with the
Right.
finding.
Right. The right side is the weak side is on the right side. No, compared to the left side.
So the anterior spinal artery, joint anterior spinal artery with involvement the corticospinal as well as the spinothalamic tract, and probably the anterior hornsel. I mean the reflex pathway also.
Okay.
Because it is.
But the problem is lesions confined to the right side.
Uh, Maybe unilateral.
The right lateral medulla.
Okay, right lateral mid, but how do you explain the absent reflexes and the radiating pain he had on the right arm?
Extending downwards and protection of the anterior horn cell.
Yeah, that's correct. Correct. Anyway, that just implicates cervical cord, but that in that case, everything can be caused. Where do we want? Where do we need to take it up middle?
Sulcal artery.
Never think the right side of the cord.
The
Okay.
right side alone can get affected if there is sulcal artery involvement.
Very
Can
good.
supply only.
So you're not thinking in terms of infarct. Okay, correct. Right. Why not distal abs? You have a severe pain in the neck, radiating down, something like a root pain.
So most likely is embolism from the nucleus pulposa, or
Okay.
fibrocartilaginous embolization to the one of the arteries.
Yeah, that's a good. That is.
That won't explain the lower limb reflex loss. This is.
None of these things in the cervical cord can explain the reflex loss in the lower limb, especially on the right side. We get a brisk reflex on the right, expect a reflex brisk on the right side, that reflex decrease. Okay, let us see what is happening. So is it cervical? What level? C5, C6 or C5 21? I don't know, because even the entire reflex is diminished on the right side. But again, difficult to explain the DTR loss in the right lower limb. Now, what investigate do you? This is MRI of the cervical spine. No obvious distinction. You just go on seeing it, and ultimately I'll ask you, what did you see in the patient? Okay, so if you want to ask me to see once again, tell me also.
There is some amount of disc bulge around.
You form an opinion, and keep it in mind, and it'll show the axial cuts also. Then only you make it. I'll show you all the fields. I'll show all the fields at various levels. I'll show you. This is axial T2 at craniovertebral junction. That is at axis level. Sorry, this is C2, C3. This is the body level. Sorry, in the intervertebral foramen level. This is the corresponding body. This is C3, C4, and this is C4 vertebral level. Now this is the area which is suspected in C4, C5 level, vertebral level. This is C5 level.
There is some hyperintensity on the right side.
Yeah, correct. And I'll ask him the end. I'll show all the cuts. This is C7 level, corresponding vertebral. C7 vertebral. This is C7 D1. D1 reflex. Now, if you want to see the film once again, I can show it, no problem. Or if it's satisfied, then I will ask you what you think is likely. Now, what do you find in this patient?
C5 level, there's a hyperintensity of the cord on the right side, and also the vertebra also is.
Okay. So what is your diagnosis?
Should be a spinal cord infarct.
Very good. Perfectly right. In fact, the vertebral is initially only subsequently found out that after coming to that. So it's got the right hemicord syndrome. Is an infarct or demyelination? That's the question to come. The following points help to differentiate infarct in this case because the abrupt onset, sparing of the posterior column, and improvement within days. How to confirm? Look at the MRI once again. We are all concentrating on the cord, but as Joy said, it's got a vertebral lesion here. That's the clue. Also, that is a normal disc C6, C7 is a normal vertebral body. Let us see the C4, C5 level. You can see that is the hyperintensity in the vertebral. And that is the point which tells you the lesion in the cord is an infarct.
But is that on the left side, sir, and the lesion is on the
correct
spinal cord lesion?
Yeah, it all depends upon where I'll come to the etiology part later, where the emboli has gone. Because but it is a radicular artery affection. Radicular artery affection due to emboli can go in direction. I'll come to that point little later. Now this is the again hyperintensity you can see there. Now if it's in fact which artery is affected, as Soumya said, it's sulcocommissure artery, because sulcocommissure artery supplies only one half of the cord, where is the posterior column. And what is causing the infarct? Most likely fibrocartilage embolism, as Uma said, because the triggering factor of the jerking in the hand preceding the pain, the neurological deficit. So all other infarct, that's what should be triggering factor of the movement of the next should occur. Now, a little bit, some few sentences about fibrocartilage embolism, then you will understand why the lesion hyperintensity can be on either side. This refers to migration of fibrocartilaginous nucleus pulposus material through the nearby vasculature to embolize into one of the spinal cord vessels. The embolic infarction can occur not only spinal cord, but also to the lung, brain, vertebra, and ribs. The initial trigger for the break of the fibrocartilage nucleus pulposus material is increased intra-disc or intravertebral body pressure by axial loading forces applied to the spine, such as heavy lifting, straining, falls, or minor traumatic events in neck and back. Once in the vasculature, the fibrocartilage embolus can enter to either arterial or venous route reach spinal cord. And to the diagram of that, if you posted the arterial route, the fibrocartilage material travels retrograde through the arterial system, supplying the spinal column, to reach the radicular artery, which carries it to the spinal cord arterial system in a normal anterograde fashion. For example, this is the pulposus. Then the broken material can enter the vessel, arterial vessel here. Normally, the blood flow artery is like this, but it will go retrogradely into the radicular artery, then goes to the side branch, enter the anterogradely, go to the antispinal artery. From there, it can go into any direction. It may be one emboli, small bits can go to various parts of the spinal cord can occur, can go to the vertebral body, can one vessel can occur. This kind of a thing can occur. This is again another picture showing you that this is how the radicular artery is coming and going to supply the vessel. It enters. This is the picture again showing the in a better way. Same thing which I have shown. This is the retrograde fashion from the disc material goes laterally into the artery, the retrograde fashion. Then anterogradely go to the spinal cord, to the radicular artery, supply this area. So this can supply this area. This can go to the other side also, can supply the vertebral body. This can occur. Then other postulate is the venous route. The fibrocartilage material gain access to the venous system of the spinal column and travel initially in a normal anterograde fashion, where they would enter the vena cava and then travel retrograde to the venous plexus of the backbone and parenchyma of the spinal cord. This theory is more plausible because there is no valve in the backbone plexus. See that here the disc material, as you should go enter into the vessels. It's a normal fashion. But from the vein, it in an retrograde fashion reach any vessel in around the cord. And this occurs especially in the setting of increased intrathoracic or intra-abdominal pressures, which promotes reversal of the venous flow away from the heart. See, this is again the enlarged view showing the retrograde flow through the vein. Now, this I think skip the temporal correlation event. The duration can be duration between the trigger event and the onset can be varied from minutes to. Weakness can be symmetric in 15% of the cases, most commonly in the cervical cord. And what you have to look for is the clue to suspect antispinal or ischemic infarct is that involvement of the vertebral body. So that's the final it's a fibrocartilage embolism causing the. Even if the vertebral lesion is not there, still that's likely diagnosis. But the vertical hyperintensity gives additional clue telling that it's likely to be infarct. Any questions?
So what about the left angle jets? How can you explain the?
That can say many things neurology cannot be explained because we don't know how to use previous angle check. His symptomatic side is the right side. So the reference on that side is more important. The left Reject maybe we don't know whether he had a disprolapse earlier, whether it's due to the faulty technique, I did not do properly reinforcement. We do not know whatever it is, it's unrelated to the present problem. We can't explain with this lesion here. In the right knee jacket also can't be explained. But time and again, I have noticed that in anti-spinal, this also I showed some time back. At least maybe up, there may be ischemia down. I don't know how it occurs. It's not seen in other conditions. Ischemia, infarct, and the anti-spinal infarct is this one. Lower lung leaflets also will be diminished. But they return quickly after a few days.
So can you show once again axial cuts?
Angle jet?
Axial cuts of the spinal cord, so C5-6.
I'll show come to that. Yeah, this is the affected area. This is the level. And again, this is what? This is compared to the right side of the cord. When the patient came to me first, I thought the patient had like disc protrusion compressing the right side of the cord. When I saw the MRI, the lesion was nothing. No, there's no disc protrusion at all. What is happening? Lesion is completely inside the cord. Then we thought of the possibility of a fibrocartilage embolism.
So the load on C7D1 is also showing some hyperintensity in the cord.
Yeah, it's correct. It's also showing it. It can extend over a few segments. You don't get it.
But it's on the other side, no? So it's on the other side of the cord, opposite side.
Yeah. This is what you mean?
Yes, sir. Yes, sir.
Yeah, there is a suspicion of it. I'm not very sure. There is some hyperintensity there. Correct. But the pulse was on the left side. Probably the mother embolism has gone into that side also.
Okay.
What I'm trying to say is that this embolic will necessarily go to one artery. There are small emboli. It can go to various territories. Go to the vertebra, it can go to the posterior part of the cord also can get. There was one picture which I had not shown you where this emboli can go like this. Okay. Any other questions?
This MRI is not showing the vertebral body infarction also in this patient.
Yeah, there is showing it. That's the fluid. This is the one which I'm showing it. Comparison I will show you every. See, this is the normal vertebral body. Out here. See, this is the one the what I was shown earlier. This is the one with affected area where the vertebral body is showing the hyperintensity. The lesson is that we normally look at only the spinal cord, look around, because but we should look around that joining area also to suspect what problem.
But the embolism can go to the other spinal artery, so the opposite spinal artery.
It can go because it is circular arteriosis. Because travel through is a circle, complete circle.
Thanks.
See, this is a circular arteriosis. See, entirely surrounding the cord. That is finished by the radicular artery. Okay, shall we go to the next case? Or any more doubts? This is another interesting case. Okay, Umar, shall I go to the next case?
Yes, sir. Yes, sir.
Now, it's a story of a 65-year-old man. His complaint started 2 weeks back as pain over the left forehead, radiating along the left side of the head up to the back of the neck, present intermittently. Along with this, he also noticed numbness of the left forehead. There's noticed ptosis of left. There's no diplopia. 1 week later, he noticed numbness of the left lower lip, which extended up to the left side of the trunk over 1 day. 1 day later, he noticed similar numbness of the right lower lip to the right hip. There is stiffness in walking and bladder retention on the next day. The complaint of 2 weeks back is pain in the left side of the forehead, radiating in the left side of the head up to the back of the neck. Along with this, he also noticed numbness of the left forehead and was noticed a ptosis of the left eye. 1 week later, he noticed numbness of the left lower limb, extended up to the left side of the trunk. 1 day later, he noticed numbness of the right lower limb up to the hip. Consciousness in walking and bladder retention on the next day. There was no pain in the back of the neck, trunk, or throat pain. No history of loss of appetite, and not a diabetic. He is a very good history and a very cooperative man. You can know. It's got dose, partial dose, which is correctable on the left side. Looking at the corrected dose. Ocular movements were all normal, except for hypermetric spectator. Hypermetric need not necessarily be abnormal also. The pupils are both constricted, so it can both normal. Lateral movement normal.
മരപ്പ് പറഞ്ഞില്ലേ മുഖത്ത് എവിടെയായിട്ടാ
He was pointing to
മരപ്പുണ്ടെന്ന് പറഞ്ഞില്ലേ മുഖത്ത് ഉടം വരെ ഉണ്ട് ഇവിടെ ഉണ്ടോ
just now, that's
അച്ഛൻ മുകളിലോട്ട് നോക്കിക്കേ
corneal liplets are bilateral.
മുകളിലോട്ട് നോക്കിക്കേ ഈ കുത്തുന്നത് ഇത് വ്യത്യാസമാണ് ഇനി വേന ഇപ്പൊ കുറവാണല്ലോ കൂടുമ്പോ പറയണേ നോർമൽ ആകുമ്പോ പറയണേ
not able to see the videos.
ഇതും അതേപോലെ അത് നോർമൽ ആകുമ്പോ പറയണേ അവിടെ ഉണ്ട് ഇവിടെ ഉണ്ട് ഇവിടെയൊക്കെ ഉണ്ട് ഇതോ
സാറിന്റെ വീഡിയോ സ്റ്റക്ക് ആണോ?
Sir, video is not playing.
Okay, sorry. I'll play it once again. Let me see. I'll stop and then play once again. Okay, 1 minute. Just 1 minute now, because it is rebooting now. Is it seen now? Is it seen?
It's not moving. It's just.
Okay. Just I will close entire thing and